Welcome to the Deep Dive. Today, we are taking on a really big topic, diabetes mellitus in kids.
Right.
We've gone through the source material, and our mission here is to pull out a clear clinical roadmap for diagnosis and those critical first steps in care.
Mm-hmm.
So just to set the stage, DM is basically a condition where you have either reduced insulin secretion or resistance to insulin. It just messes up how the body handles carbs, proteins, and fats.
And for our purposes, in the pediatric world, we're really looking at three main types. There's type 1, the autoimmune kind we all know.
Okay.
Then type 2, which, is getting more and more common in children. And then there's a third one, monogenic diabetes, or MODY.
MODY, right. We'll get into that. But the biggest takeaway, the thing that shapes everything that follows, is this one initial question.
Yeah, the first branch in the road.
Exactly. The first question isn't about labs, it's about triage. Is the patient stable or unstable? That one thing changes the entire game.
It absolutely does, because if that patient is unstable, you're in an emergency situation. You don't have time to think about differentials.
It's all hands on deck.
All hands on deck. You're straight into the ABCDE protocol: airway, breathing, circulation, and you're getting IV access, fluids, monitoring right away.
So walk us through that. What does an unstable patient actually look like in this context? What's the picture that screams DKA?
So instability almost always means diabetic ketoacidosis, DKA. You're looking for those classic high sugar symptoms.
Excessive thirst, urination.
Right, but now you add severe GI problems. We're talking relentless vomiting, bad abdominal pain. Sometimes it even looks like appendicitis.
Wow.
And the most serious sign of all is any change in mental status. Confusion or just extreme sleepiness, somnolence. That means the body is acidotic.
And one of the most sobering stats from our sources is just how common this is at first presentation.
It's shocking.
Up to 25% of kids with new onset diabetes first show up in DKA. A quarter of all diagnoses are made in a crisis.
Exactly. And that's why the physical exam is so urgent. You might see that sleepiness right away. Vitals will probably show a fast heart rate, low blood pressure from the dehydration.
Okay.
But the absolute, the dead giveaway is their breathing. It's a pattern called Kussmaul respirations. Deep, rapid, consistent breaths.
Kussmaul breathing, that's the body trying to fight back, isn't it? Can you just break down that mechanism for us?
Yeah, it's the body's desperate attempt to fix a severe metabolic acidosis. It can't get rid of the ketones, the acid, quickly enough.
Right.
So it tries to blow off the one acid it can control, carbon dioxide from the lungs. So they're just hyperventilating, trying to raise their blood pH.
And I imagine there are other physical clues.
Oh, yeah. You'll see very dry mucous membranes, and then there's that very distinct fruity smell on their breath. That's acetone.
So once you see those signs and you suspect DKA, you need to confirm it with labs. What are the core things you're looking for in the blood work?
You're really confirming three things at once: high sugar, high acid, and high ketones. So blood glucose will be over 200. For the acid, you're looking for a low arterial pH under 7.3 or a low serum bicarb under 15.
And the ketones.
And for the ketones, you'll see a beta-hydroxybutyrate concentration of 3 millimol or higher. All three together, that's your DKA diagnosis.
Okay, so let's get into management. IV fluids, an IV insulin drip, and very close monitoring of electrolytes.
Yes, especially sodium and potassium. And that monitoring is so critical because of the one complication we have to avoid at all costs.
Cerebral edema.
Cerebral edema, swelling of the brain. If you correct that high blood sugar too quickly, you cause a massive shift in the body's fluid balance.
And water rushes into the brain cells.
Exactly. And that can cause seizures, permanent brain injury. It's a nightmare scenario.
So if you even suspect it's happening, what's the move?
Intravenous mannitol. Immediately. That's the emergency treatment to pull that fluid back out of the brain tissue and reduce the pressure. It's your safety net.
Got it.
And just quickly, before we move on from acute problems, we should mention hyperosmolar hyperglycemic syndrome, or HHS.
Right, people confuse it with DKA, but it's different.
Very different and much rarer in kids. It's more of a type 2 thing, usually in older teens or adults.
What's the easiest way for our listener to keep them straight?
Think of DKA as an acid emergency. Low pH, tons of ketones. HHS is a concentration emergency. The blood sugar is just astronomically high, like over 600.
Yeah, over 600.
Yeah, the blood is incredibly thick, very high osmolality. But, and this is the key, their pH is usually normal and they have almost no ketones. They make just enough insulin to prevent that massive breakdown of fat.
That's a super helpful distinction. Okay, let's leave the ER. Let's shift gears to that other pathway. The patient walks in, they're not in crisis, they're stable.
Mm-hmm.
Now we switch from saving a life to making a diagnosis. The first step here is a good, focused history. We're looking for the classic 3 Ps.
Polydipsia, polyphagia, and polyuria.
So excessive thirst, excessive hunger, and excessive urination.
And with kids, that polyuria has a really specific sign that parents pick up on. It's not just that they're going to the bathroom more.
It's the secondary enuresis.
Exactly. A child who is perfectly toilet trained for years suddenly starts wetting the bed again at night. That is a huge red flag.
A very practical indicator. And then you're also asking about weight loss or family history of not just diabetes, but other autoimmune stuff, right?
Yeah, things like thyroid disease or celiac disease, they often travel with type 1.
Okay, so the history is pointing strongly towards DM. How do you confirm it?
With the patient stable, you have a few options for testing. You can use a hemoglobin A1C, which shows the average blood sugar over a few months.
Looking for 6.5% or higher.
Correct. Or a fasting blood glucose of 126 or more.
Hmm.
Or, if the child is really symptomatic, just a single random blood glucose over 200 is enough to lock in the diagnosis.
So now we've confirmed it. It's definitely diabetes. But the real deep dive starts now, which is figuring out what kind of diabetes it is.
This is where the specialized labs come in. We need to find out how much insulin the pancreas is actually still making, if any.
And to do that, you order C-peptide levels and a panel of islet cell autoantibodies, like GAD65.
Yep.
That's right.
Okay, let's talk about C-peptide for a second. Why that? Why not just measure insulin directly?
That's a great question, and it gets to the heart of how this works. See, insulin and C-peptide are produced together from a larger molecule called proinsulin. They're released in a 1-to-1 ratio.
Okay.
But insulin gets cleared by the liver really fast, so its level in the blood can be all over the place.
Mm-hmm.
C-peptide, on the other hand, hangs around a lot longer.
So it's a more stable marker. It gives you a much better sort of big picture view of how much insulin the pancreas is capable of making overall.
Precisely. It's a much more reliable indicator of total beta cell function.
Perfect. So let's follow that first path, the most common one in kids, type 1 diabetes.
So for type 1, the lab results are pretty clear. You're going to see very low C-peptide levels.
Because the beta cells are being destroyed.
Right. And you'll see positive islet cell autoantibodies, which confirms that it's an autoimmune attack. This patient has a severe, usually absolute, lack of insulin. And the management is, of course, insulin therapy. But the complexity here is, it's just immense.
It is. The starting dose is usually around 0.5 to 1 unit per kilo per day. But that's just a starting point. It has to be split.
50% is a long-acting basal insulin to cover the background needs.
And the other 50% as rapid-acting bolus doses for meals.
Which brings us to the constant mental math that families have to do.
Oh, it's a huge cognitive load. You have 2 main rules to start with. First, the carb ratio. 1 unit of insulin usually covers about 10 to 15 grams of carbs.
Okay.
And second, the correction factor. 1 unit of rapid-acting insulin will typically drop their blood sugar by about 50 points.
But every meal, every snack, every time they get sick or play sports,
Yeah.
it all requires new math, new adjustments. It's a whole new way of life.
It is. It takes intensive education, dietetic support, carb counting, and you have to constantly screen for those other autoimmune conditions we mentioned, like celiac and hypothyroidism.
Thankfully, the technology has really helped. Continuous glucose monitors, or CGMs, have been a game changer.
Absolutely.
And insulin pumps, these wearable devices that give a continuous fine-tuned drip of insulin. They're both just so vital for preventing those awful long-term complications.
Retinopathy, nephropathy, neuropathy, yeah, tight control is everything.
Okay. Let's switch to the other paths, the non-immune types. So these are the patients whose labs come back with normal or even high C-peptide.
So their pancreas is still making insulin.
And they have negative antibodies. So we know it's not an autoimmune problem. Now we have to figure out, is this MODY or is it type 2?
Exactly. And you start to suspect MODY if the patient is young, usually under 25, and you see this really strong multi-generational family history of diabetes that just doesn't really fit a typical type 1 or type 2 pattern.
So if you suspect MODY, what's the first move?
Genetic testing. That's the key. MODY is caused by a single gene mutation passed down in an autosomal dominant way. And the problem isn't insulin resistance.
What is it then?
It's impaired insulin release. The beta cells can make it just fine, but the mechanism for secreting it is broken.
And that's a fundamentally different problem, which must lead to a totally different treatment plan.
It does, and that's why getting this diagnosis right is life-changing. Many MODY patients can be managed without any insulin at all. They respond really well to oral drugs, sulfonylureas, that just help stimulate the pancreas to push out more of the insulin it's already making.
So you could take a child off of daily injections and put them on a pill?
A pill plus education and genetic counseling for the family. It's a massive difference.
Wow. So then, if the genetic test is negative, or if the patient just fits the classic picture of insulin resistance, we're leaning hard towards type 2.
Correct.
And what are those classic features we're looking for?
Well, you're looking for signs of metabolic syndrome, a family history of type 2, an elevated BMI, high blood pressure.
And that skin finding, acanthosis nigricans.
Yes, that dark, velvety skin on the neck or in the armpits. Type 2 is that dual problem. Your body is resistant to insulin, and then over time, the pancreas just gets worn out and can't keep up.
And the management for pediatric type 2.
It starts with really intensive lifestyle changes. Diet, exercise, anything to fight that insulin resistance. The first-line drug is almost alwast metformin.
But some of them will eventually need insulin too, right?
Yes. As that pancreatic function declines over time, many will eventually need insulin to maintain control.
That was an incredibly clear roadmap, from the emergency of DKA to the genetic detective work of MODY.
Mm-hmm.
So let's just recap the big takeaways for you. If you suspect DM, first, check for stability. Unstable patient means DKA protocol, fluids, IV insulin, and watch out for cerebral edema.
Right.
If they're stable, you run the diagnostic labs. Once it's confirmed, you get your typing labs. C-peptide and antibodies. Low C-peptide and positive antibodies is type 1.
And normal or high C-peptide with negative antibodies means you have to dig deeper to separate type 2 from the genetically driven MODY.
Exactly.
And, that brings up a really interesting final thought. The existence of MODY, a form of diabetes we diagnose purely by finding a single gene mutation, it really makes you question our old framework. Well, is our traditional focus on just type 1 versus type 2 becoming a bit obsolete? As genetic testing gets faster and cheaper, you have to wonder how that might change our whole approach. We might get to a point where the first question isn't, is it type 1 or 2, but rather, is there a gene driving this hyperglycemia, and let that answer guide the entire treatment from day one.